Hello, everyone, and welcome to our Health Equity Roundtable series. I am your host today, Sarah Maines. I'm the director of the Liver Cancers Program at Global Liver Institute. We are so happy that you are joining us for our October for Livers campaign. We are once again focusing on raising awareness about liver cancer through our annual campaign called October is for Livers. And this October, GLI will continue to drive equity by connecting with diverse communities around the world to push boundaries amongst the liver cancers community. Today, we continue our series of Health Equity Roundtable conversations to discuss challenges and potential solutions to tackle liver cancer together. In this episode, we are joined by leading experts in rural health and health disparities from the U.S., Cameroon, and Mexico for a very important discussion on health equity in rural populations. Please join me today in welcoming Dr. Andrew Moon, transplant hepatologist and assistant professor of medicine at the University of North Carolina, Chapel Hill School of Medicine. Joining the discussion with valuable insights is Dr. Bianca Leavencliffe, a Cameroon-based medical doctor, public health specialist, and CEO of Empower Women's Foundation. And lastly, we are honored to welcome Dr. Jorge Emilia Lira Vera, hepatologist, gastroenterologist, and head of the liver clinic at Hospital Central, Dr. Ignacio Morones Prieto. Thank you all for being here today. We're so glad that you've joined us. I wanted to begin, before we dive into our roundtable questions, first for you to each briefly talk about your experiences and passions as it relates specific to rural communities and liver health. Thank you so much. Dr. Moon, would you like to begin?
Sure. Thank you so much for the introduction, Sarah, and thanks so much for having me. It's a real pleasure to be here and speak about such an important topic. As you had mentioned, I'm a transplant hepatologist at the University of North Carolina, or UNC, and I practice within our multidisciplinary hepatocellular carcinoma clinic. My research focuses on improving outcomes for patients with liver cancer, including addressing disparities in care. And as a provider at UNC, I'm lucky enough to serve patients from all 100 counties in North Carolina. And rural health is particularly important and relevant to us, given that North Carolina has the second largest rural population of any state in the U.S. So this is something that we see on a regular basis at our medical center and throughout the state.
Putting you on the spot quickly, do you know the first highest population?
Texas.
Okay, I assumed that and wanted to check. Thank you so much. That's interesting, and that statistic wasn't in the top of my mind today, so thank you. Dr. Leavencliffe, welcome. We would love for you to give an introduction and talk about your rural health and liver health experience and passion.
Thank you so much, Sarah, and I want to thank you for having me on this roundtable discussion. It's always a great pleasure having such discussions and trying to raise awareness of liver health problems, especially liver cancer, which in our setting, unfortunately, doesn't get much momentum. So my interest in liver health began as a medical doctor in my medical practice. I was head of the hepatitis unit in a local hospital, and I was overwhelmed with the number of cases of hepatitis B and C in a very small community, and that spawned me into liver health research. I wanted to know why the hike of numbers of cases of hepatitis B and C, and why public health wise there are little or no data and momentum in regards to that domain. And so that is what pushed me to in researching about liver health, hepatitis B and C, and liver cancer, which over the years has been the focus of my research as a public health specialist. So the communities we work with as Empower Women Foundation are very remote and rural communities with very limited access to diagnostic equipment and very limited access to even to a health center. So these are the populations that have the greatest burden of hepatitis B and C, and who are at higher risks of liver cancers. So I think it's very important for me in this domain to try to see how we can wrap up discussions about this and see how we can look at what we can be done in settings like mine that I currently work with and I'm faced with such challenges on a daily basis. Thank you.
Thank you so much. Dr. Rivera, hello. Welcome and thank you for being here today. We would love to hear about your background serving the rural community along with the liver health community.
Hi, good morning. Thank you, Sarah, to you and of course the Global Liver Institute for the invitation. Briefly, I am the head of the liver clinic at Hospital Central in the city of San Luis Potosí. And this city is the capital of the state of the same name, San Luis Potosí in Mexico. And my hospital is a center that provides care to patients without public or private health security. We provide care to a large volume of population, not only from the capital city, but also from all over the state. And this means that our patients come from the capital or from some places so far away that they have to travel maybe 6 or 7 hours by road. And the reason for such long trips is because my hospital is the only public center in the state that provides pathology care to this population. This means that almost half of our patients come from rural communities. And we also see patients through telemedicine every week to try to reduce the need for them to travel. And it has been exciting to build the liver clinic in my center, always the aim of helping each patient in the best way possible, not only in the prognosis of their disease, but also in their quality of life, as well as reducing the stigmas that they suffer, mainly in those rural communities.
Thank you so much. You know, when I look at our screen right now and see the three of you, I feel so grateful to be able to have this important conversation and look at ways that we can lift you up, and thank you and all of the other hepatologists and HCPs that are helping with rural health. I think this conversation is so important and will be impactful. Dr. Moon, I want to speak with you first. For many years, liver cancer rates in urban areas exceeded those in rural regions of the US. However, in recent years, there's certainly a significant rise of liver cancer and liver disease rates in rural areas. I'm wondering if you could provide insights into factors that contribute to that shift that we're seeing, and are there specific risk factors or barriers to healthcare access that are driving the increase of the liver cancer incidence that's unique to rural US?
Sure. Yeah. So recently in the US, we've seen some potentially encouraging signs that overall liver cancer incidence and deaths may be beginning to plateau. However, this is not occurring in rural communities, and disparities in liver cancer outcomes between rural and urban residents are beginning to grow. Now, I think there are a number of factors that are driving these concerning trends. And I think one of the biggest factors is disparities in underlying liver diseases that lead to liver cancer. So the vast majority of liver cancers develop in people with underlying liver disease, most often patients with cirrhosis. And the main causes of cirrhosis are chronic hepatitis C, hepatitis B, alcohol-associated liver disease, and metabolic dysfunction-associated steatotic liver disease, or MASLD, which used to be called non-alcoholic fatty liver disease. So we know that diabetes and obesity have been on the rise. That's leading to more cases of MASLD. We know that high-risk alcohol use is rising, particularly after COVID-19, and that's leading to more cases of alcohol-associated liver disease. And these trends may be more pronounced in rural areas. Now, hepatitis B and hepatitis C have been relative success stories recently. We have a highly effective hepatitis B vaccine with universal vaccination efforts. There have been fewer cases of chronic hepatitis B. And we now have very effective treatments for hepatitis C that result in cure in more than 95% of cases. So this is great that we have these tools, but despite recommendations that everyone get screened for hepatitis C, many people with hepatitis C remain infected without knowing it. And even for those who know it, there may be barriers to getting these highly effective treatments. So I think this is part of the reason the patients who are living in rural areas probably face more of these barriers. And these underlying liver diseases are likely playing a large part in the growing disparities in liver cancer cases.
Thank you. Out of curiosity, Dr. Lira, as a hepatologist working with both rural and urban populations in Mexico, how do you observe disparities in liver health that's manifesting across individuals from different regions? And I'm curious if there's particular regions where patients tend to present with more severe cases of liver disease, and what factors contribute to those variations?
Well, of course, first of all, it is important to be clear that the first drawback in the care of liver diseases is the lack of hepatologists throughout the country. Most of them are located in the three big cities of the country, of course, Mexico City, Guadalajara, and Monterrey. And only a few of us are based in the rest of the country. And this already reflects a first obstacle to be faced, because even some urban regions have a lack of hepatologists. And second, well, patients from rural areas are at great risk of having their liver disease detected in more advanced stages, including, of course, hepatocellular carcinoma. And it is very common that their quality of life decreases proportionally to the progression of the liver disease. So this not only impacts the patient's health condition, but also on their family environment. For example, the household income, and it difficults their medical attention. In our country, alcohol is the main cause of liver disease, but MASLD has been rising in the last years. In some rural communities, MET-ALD is the growing cause of liver disease, and some stigmas are very common in rural communities. Even if the cause of chronic liver disease is not alcohol, there is a belief that only cirrhosis develops because of alcohol abuse. So this causes that patients seek medical attention much later in their disease, as they fear that when their condition becomes known, they will be judged. And regarding alcohol consumption in Mexico, another belief is that some typical Mexican beverages, such as aguamiel or pulque, which have been alcoholic beverages since pre-Hispanic times, are not alcohol, and they are drunk from a very early age. So this increases the burden of liver disease when the people get older. And certainly rural regions tend to have the most advanced liver disease because of the factors that I have mentioned. But in addition, even in certain areas, access to upper endoscopy, for example, is scarce, which makes various allegations program difficult. And this also delayed recognition of advanced chronic liver disease, which facilitates the development of decompensation.
Thank you so much. Dr. Leavencliffe, chronic hepatitis B and C infections are well-established risk factors for hepatocellular carcinoma, or HCC as we know, and Cameroon has a notably high prevalence of hepatitis B, particularly in rural regions. Can you elaborate on the factors that contribute to the high rate of hepatitis infections in rural Cameroon and what challenges rural communities face in addressing that issue?
Yes, thank you so much, Sarah. And I just want to state, just like in the US, there have been a tremendous shift in the incidence of liver cancer and liver disease between the urban areas and the rural areas. Back in the 2000s, that is 2001, 2002, we have the urban areas bearing the greatest share of the burden. But in 2016, there was a tremendous shift with the rural communities now bearing the highest incidence of hepatitis B and C infections, liver cirrhosis, and liver cancer in the later stage. And a lot of public health specialists like myself and Dr. Mauda that has tried to understand like the trends of this liver disease and why there has been this shift among urban and rural populations. And our research notably find out three great contributors, which first is the greater awareness that have happened within urban populations. Urban populations have had more awareness and sensitizations, and as such, they are taking precautionary reasons to prevent hepatitis B and C infections, and also the somehow access to hepatitis B and C vaccines, and also to diagnostic interventions that can easily diagnose the disease early. So in urban areas, there have been tremendous work done in diagnosing early, in prevention, and also in management, which are not found in the rural communities, unfortunately, especially when the crisis broke out in Cameroon in 2016. We have a lot of migration that has been pushed towards the rural areas, and we have those rural areas which were before not densely populated, now heavily populated, with limited access to diagnostic equipment, limited access to vaccines, and limited access to management centers. This has contributed to the high incidence and prevalence of hepatitis B and C infections, and possibly liver cancer, as we know in these areas. And unfortunately, the interventions that could be done and that we carry out in urban areas are more constricted because of the crisis. A recent story that I will soon share with us, a recent publication that we have, we realize that much of these cases are from IDPs that are concentrated in IDP settlements, and also from refugees crossing within Nigeria and Central Africa. They carry about 67. The research suggests that they carry 67% burden of hepatitis B and C cases within our country. So we sincerely believe that this is what is driving these incidents in rural areas, and the challenges we face are enormous. The first challenge we face is political will. It being a political crisis and a lack of political will to actually improve on care in these areas has been a major challenge. These areas have been markedly unaccessible by humanitarian actors, by private sectors, and by the government itself, and thereby leaving the population with little or no help. Secondly, we noticed that hepatitis centers are being set up in just 4 regions in the country, which are a great kilometers away from this population. Thus, it will take an average patient about approximately 6 to 12 hours to get to a center that the person can be properly diagnosed. So there is an uneven distribution of diagnostic centers and management centers around the country, making it very, very inaccessible to people to easily diagnose and easily manage liver diseases. And also, thirdly, we have a lack of community awareness and sensitization in these public areas. And that is because of the high illiteracy rate that is marked by these populations, and also the fact that the populations being IDP settlements and mostly refugees have what we call a discrimination ideology. They are largely discriminated in terms of health services and in terms of reach. So I think these are the barriers that we face within this country, within these settlements, and we really need to up the game. And I think organizations like ours, being civil societies, really need the support to see how we can navigate these barriers and see how we can reach these populations that have been highly discriminated.
Thank you. I think that discrimination and stigma are so important when we speak to rural health. You know, one of the areas, and you had mentioned refugees or immigrants, what does that play hand in hand with stigma and discrimination as well? So I really appreciate you talking about that. I think that there certainly would be similarities with all three of you. And please, a reminder, Dr. Vera, Dr. Moon, at any point, please join if you have questions or comments too relating to each other's background or specifics that we're talking about today. Dr. Moon, I appreciate now that we've covered risk factors that impact cancer rates for the U.S. rural communities. What are the most significant challenges faced by liver cancer patients in rural U.S. communities when seeking treatment? And specifically, kind of the second point to that question is, how do factors like distance to the specialized care centers, Dr. Levencliffe, you just mentioned that, the healthcare provider shortages and limited insurance and some of those socioeconomic barriers, how is that impacting ability to receive timely care and effective treatment?
Yeah, it's a great question. And I suspect, based on the answers of my colleagues here, that the barriers that patients face will be similar in a lot of rural communities throughout the world. This is an issue I see come up pretty much every week in our multidisciplinary clinic. So to give you a sense of the potential barriers, let me quickly take you through what a liver cancer patient may go through pre and post treatment for their liver cancer. So oftentimes a patient with liver disease will have a mass found on ultrasound. They'll need to then schedule a CT or MRI to definitively diagnose the hepatocellular carcinoma. If it's indeterminate, some patients need a biopsy after that. Once the diagnosis is confirmed, they're then referred to a separate treatment specialist. Treatment options are discussed. If they receive a liver-directed therapy, this involves several more visits. If they're referred for systemic therapy, they're coming in every 3 to 4 weeks for infusions. If they're a candidate for liver transplant, then this involves a whole separate group of medical evaluations and visits. Even after they receive treatment, they're requiring MRIs at least every 3 months, given the very high risk that liver cancer returns. So co-located multidisciplinary HCC clinics, like the one I'm lucky enough to work in, allows patients to at least see their hepatologist, an oncologist, interventional radiologist, and or surgeon on the same day. But these types of clinics are relatively rare in the U.S. And so many patients are not able to be seen at these types of clinics. They're great because they do improve patient satisfaction. They reduce delays to treatment, and they've been shown to improve overall survival. But even for those who are referred to these types of clinics, you know, it often involves multiple hours of travel, and they may not be referred in the first place for a number of reasons, including, as you mentioned, insurance coverage and other socioeconomic barriers. And in fact, we performed a study looking in the entire North Carolina population to look at predictors of being referred to a specialized center. And patients who lived in rural areas were much less likely to be referred to a specialized center within 3 months of their liver cancer diagnosis. So these data showed that this is a very pervasive issue.
Would you say, you know, in terms of that pervasive issue, is it lack of knowledge or understanding of the health system when the diagnosis happens? Is it coming from a primary care physician or a generalist that they're referring straight to a GI specialist instead, and also because there's not a lot of hepatologists? Or what would you say that main breakdown is that GLI might be able to help with connections and advocacy work in that space?
Yeah, I think there's, generally speaking, liver cancer is much more difficult than many other cancers. So always tell patients and community providers that you're really dealing with two diseases. You've got the chronic liver disease and cirrhosis, and the liver cancer itself. And so I think there is a lack of knowledge about the importance of being seen at specialized center where you can get care for both. And I think education of both patients and providers would be immensely helpful.
Thank you. I appreciate that. Dr. Leavencliffe, as we dig deeper into the issue of hepatitis infection in Cameroon, can you discuss if cultural beliefs and stigma are impacting the spread of hepatitis and the effectiveness of its management in the region? And can you provide insights on how these factors might play an influence in the overall situation of liver health?
Yes, cultural beliefs have always been a great barrier in a setting where people lack access to information, where access to information is very difficult. People tend to use their environment and your culture to frame what they think. So, and that has been the greatest challenge, especially when we indulge into several community education and sensitization campaigns. We feel like patients, the greatest rumor coming out from community is hepatitis is ascribed to witchcraft. Like they don't believe it is natural. They believe it's spiritual. Thus, they sought a spiritual means to resolve their problems. Like for example, we were in a community last month, and we were interviewing a somehow witch doctor that happens to cure a lot of people from hepatitis from by doing so many rituals. And we were just, as medical practitioners and researchers, were curious to find out like how these practices are and what he's been doing, and we were amazed. And that half of the population goes to this man for their medical for their health advice, and also for management. And we have a lot of patients that are presently are receiving this spiritual management from him, and who were being referred to by a community agent that referred us to this guy. And we went there, we discussed with him, and he described his process and testimonies of the number of people he has helped snap out of hepatitis B and C. And until we brought back with us some of the stuff and the chemicals for further investigation. So you get a population that do not have access to information, and that are left with testimonies from other people who are supposedly being cured by this practitioner. So a lot of them believe that this thing can be managed spiritual, especially when in our case where we don't have access to liver transplant, we don't have access to radiation management and all the sophisticated management. We don't have it here in our country. So this leaves the population to believe that their solution is only spiritual, and the causes is spiritual. And this has affected how people seek healthcare, and how they will interpret the advice from a healthcare practitioner. I remember in 2018, I had one case of liver cirrhosis, and I was trying to run through the patient, my counsel, and all the management options that they have. And the patient boldly tells me that, "Doctor, thank you. I just wanted to know what is wrong with me. I have somebody in the village that is going to handle this issue." And I was a young medical practitioner, and I was astonished, and I was like, "What?" It was shocking to me. And that's how the patient left. I went to the village and saw whatever intervention the patient had. And this patient later returned to Ottawa 2 years after, and the condition has gotten worse, and the patient died. So these are the number of patients who believe that we don't have the management capacity. The causes are spiritual than physical, and thus the only cure is a spiritual solution. And this is what is causing a lot of the deaths due to liver cirrhosis, a lot, and liver cancer, because they don't seek medical attention early enough. They seek spiritual intervention and only get back to the hospital when there's little or nothing that could be done.
Have you found any luck in meeting with the spiritual advisors, if you will, if there's a better term, please say so, in giving them insight and education about what you are doing that's different from them? Or is there a way that patients can co-manage or work with both you and that spiritual advisor? What does that look like?
Yeah, I think with Africa and the whole scenario regarding traditional medicine and spiritualism, and with our healthcare system going to be more inclusive, we are looking at approaches. I think like I personally throughout my organization has reached out to a number of them for collaboration. But the challenge has been, there was a recent policy that was issued out from the presidency banning the practice of traditional medicine, and that caused a lot of tension and upheaval and lack of engagement and collaboration with the traditional practitioners, because they fear that we are luring them to be arrested and prosecuted by the state, and that has had a great impact in the health of the populations. And also we are seeing that a lot of populations are boycotting hospitals, and a lot of clients cannot report that they are visiting traditionalists because they fear that they will be implicating them, and thus we are seeing a rise in death. Because before there was this collaboration that we could actually train the traditional practitioners. We can actually train them, and we collaborate for them to refer patients to us early. And we had a great success when we do that, because we show them the limitation of their practice and how they can practice modern traditional medicine with our diagnostic abilities, and how we can collaborate together. That's why most of the substances they use, we try to go to our regional traditional labs to investigate what are the active ingredients that are present within their substance, what are the dangers of the substances, and how they can make it more safer for patients, and also try to introduce them to us our own the conventional way of managing such diseases, because we believe that when they are empowered, when they collaborate with us, we have better outcomes. But if we shut them out, we cannot stop patients from going to them, because it's a cultural root. If we shut them out, we have more and more liver disease cases, more and more deaths due to liver cancer. So I think that it's important that we try to give streams for collaboration, avenues for collaboration, rather than shutting them out. And that is the challenge we are facing now from the recent ban by the government, and it has made things worse for us than before.
Thank you very much. I think it's so important to talk about traditional medicine in that sense, and what we can continue to do and the hardships that are connected to that. Dr. Rivera, I'd like to talk to you about the primary accessibility challenges for hepatology care in rural Mexico. You spoke to that about the lack of access to hepatologists and the lower amount of hepatologists in Mexico. For patients who can't access a specialist locally, what does travel burdens look like to them in terms of cost, distance, transportation availability, and how in return does that affect the timeline of the diagnosis? Continuity of care obviously is a part of the issue, and then overall outcomes for them. Can you speak more about this?
Of course, it looks like the three of us have to face the same problems, but in our very own way. The fact of having to make a trip from their place of residence of these patients to the hospital, I think is the factor that implies several inconveniences for the patients. Not only because of the hours they must invest to travel, but also, as you mentioned, the economic burden they must spend on transportation and even accommodation in some cases, because they have to travel a lot of hours from home. And of course, then comes the time the patient has to wait for the appointment to be scheduled because of the lack of pathologists, in some places, even oncologists. So their attention can be delayed for some weeks. And this has led to search for an alternative way to bring that health care that they need. And I think this option can be telemedicine. This can be a tool against the hours of travel and waiting time for an appointment. However, to achieve appropriate care, it is necessary for telemedicine medical staff to be highly trained in the detection and of course, the initial management of chronic liver disease. And in some areas, this is a point for improvement in these days. I think it works for us, the hepatocellular carcinoma screening programs every 6 months by ultrasound. It's cheaper in our country, and this is done very well by local doctors and can be followed up without problem by telemedicine. And when any suspicious mass appears in the ultrasound, they can be referred to our center as an urgency case. Regarding the travel burden, some people have to travel more than 300 miles and spend more than 6, even 7 hours in that journey. And it's not just the time, it could be also expensive, particularly when the patient needs to travel with a relative. Some rural areas, for example, have limited bus schedules. So sometimes the patient and their families have to spend at least one night in the city, and of course the cost of this rises. By the other hand, it's true that some areas have transportation provided by the local government, but not all the communities have that help. And of course, there is no question about it. These barriers affects every single step of this attention. Of course, the diagnosis could be late, and that is the reason of the development of the compensations, including, of course, liver cancer. And this situation impacts in a bad way the outcome because liver cancer progresses and the curative window is closed most of the time. So I think the highest goal most of the time in this patient is just improving quality of life, which is very important regardless of hepatocellular carcinoma stage. But of course, it impacts in a negative way the prognosis of our patients.
Thank you very much for that. So much to do. It's layered. This is complicated. I think a lot about in these conversations, not only to bring insight and awareness with all three of you, what you see, also being able to not only share those challenges, but also talk about what works well and what's kind of lessons learned from each rural area that we're talking about today that can help all of us improve these outcomes. Given the unique challenges faced by rural communities, the limited access to healthcare facilities, fewer specialized liver cancer treatment centers, transportation difficulties, a question for all of you, what are the strategies that your regions or healthcare facilities are implementing to help address these barriers? What does telemedicine look like for your countries or your specific healthcare institutions? Are there partnerships that we can do? Are there policy changes within your countries or states that we can leverage to help with early diagnosis, treatment access, outcomes? Dr. Rivera, would you mind starting to talk about strategies that your country is addressing?
Well, the local doctors are being trained in the early identification of chronic liver disease. And they are learning how to approach these kind of patients and what conditions they should evaluate at each visit. as well as, of course, the alarm data to timely refer patients to our hospital. And when the patients get better, they can be discharged from our center and be followed up by telemedicine. We have a program to search by ultrasound, as I told you before, liver lesions. And in the event of suspicious lesions, a consultation is made by telemedicine, and the CT scan is performed even in the community of the patient when it is available, of course. If it is not the case, they are referred to our center, and they are referred as an emergency. To avoid the delay of time of, arrive at the hospital and go to a consultation first and then go to a radiology department. And we also have some educational programs to the patients, to the communities, because at least in our country, alcohol consumption is higher in some areas, especially in the rural communities. And as I told you before, in these regions, the stigmas are very common. So in our country, this stigmas is a barrier to the people for looking for medical attention. And we try to do this public education or have this kind of programs to educate communities, to eradicate this kind of wrong ideas.
Thank you, Dr. Lira. Dr. Moon, curious what that looks like that you and your team and facility implement to help reduce some of these barriers.
Yeah, so I think, as we had already discussed, improving awareness is step one. And it's not only improving awareness among providers in the community, but also improving awareness among patients and making sure they feel empowered. I think I'm so glad we're having a session like this today to discuss these issues. And I think patients should know that you should always ask about your options. You should always seek a second opinion. Ideally, if you're diagnosed with liver cancer, be seen at a multidisciplinary center with expertise in liver cancer, given how difficult its management is. Costs are a trickier issue. We at UNC are lucky to have a wonderful financial support system to help patients who are uninsured or underinsured. But I think when you're looking at system-wide improvement, we really need national legislation to plug some of the major gaps in our healthcare system. Transportation costs, as we've all alluded to, are tough to overcome and often unavoidable for patients. One silver lining of the COVID pandemic was the increased use of telemedicine. But there's still some issues with telemedicine. Legislatures need to understand that these types of visits are incredibly important for rural patients, and need to know that it's important to continue reimbursement for these types of visits. Infrastructure is an issue. So many patients in rural communities don't have access to broadband internet, so it can be harder to conduct video visits. And when it comes to liver cancer, obviously we can't perform MRIs or CTs after their treatment at home. But it is sometimes possible to find a local facility who can perform these scans, get the scans sent in to us so the patient can do this more conveniently and more cost effectively. In the near future, I'm very optimistic that we may have blood-based biomarkers that could be used to more conveniently diagnose and survey liver cancer. And this could have an outsized impact for patients in rural communities.
Thank you. So helpful to hear more. And Dr. Levencliff, curious what that looks like for you in Cameroon, and based on the similarities that we've just heard from the other doctors.
Yeah, I think in Cameroon, what we have engaged in, we use the acronym that is KRR. KRR stands for Know, Reach, and Receive. So in under Know, we says health professionals have to know what to do, when to do it, and how to do it. Patients need to also understand that they need help and they need to seek help. That talks about raising awareness and community educations. And also we look at now caregivers. So we put the continue, we put patients, the providers, the caregivers, and the policymakers. The policymakers also need to know the burden of the disease, the problem, so that they will start looking, taking actions to design policies that will favor liver health. Now, when we go now, that is what our organization have been engaging, making sure that we have like through JLI, we have been having so many Octobers for Livers campaigns where we put healthcare providers, patients, caregivers, and policymakers together in one room, and we discuss these challenges. So that is a part of the knowing. The reaching now is how do we improve accessibility to diagnostic and management services. So our organization have been supporting health centers and royal facilities with hepatitis B and C strips for free. We have launched so many free campaigns on hepatitis screening campaigns on hepatitis B and C. Through our advocacy, we have had the government greatly reduce the price for hepatitis B and C management, the drugs and all that. So that is how we are looking at how do we make sure that when the patients are aware, and how can we make them accessible to these services. The last arrow stands for receive. Receive, now we are focused on training, because it's one thing for the people to know that they need help and they have access to help. It's another thing for the helper to have the capacity to offer the help. So how do we focus on trainings for healthcare providers so that they will be able to give the help that is needed? This has been a greater challenge because, with limited financing, there's pretty little much we could do in such organizing such training. I think most of these specialty trainings need high finances, and those modules are not available within the country. You need healthcare providers to have course training programs abroad for them to be able to up their knowledge and training practices. So that has been a greater part of our challenge, and we are hoping that with such collaborations with GLI, we can see how we can be improving access to such specialized trainings for healthcare providers who are actually practicing in our context. So that is what we have been doing. That is what we are engaging in. And we think that with your support, with the support of GLI, and with the support of my colleagues here today, we can form a partnership where we can see how we can advance care in a setting like us, how there should be somehow a cross-cutting knowledge sharing and capacity building for each one of us, because I think we live in a similar scenario, and our experiences and our knowledge sharing will be very, very important and much needed to really advance the care that we provide for patients.
Thank you so much. One of the things that you mentioned was that caregiver aspect. I do think that that's so important in the context of this conversation. All of you have talked about the hours and hours and hours it takes for some patients to drive to receive specialized care. And that's likely not just the patient being singular and alone in that, and also what that impact does with those caretakers and providers to follow up with ongoing continuity of care, the time that it takes out of their days, the lack of being able to work and the cost associated with that. So thank you. And equally, Dr. Leavencliffe, you just talked about connecting the dots and what that looks like, that there's a larger picture. There's so many different people and players involved with making some of these changes. We've been doing these health equity roundtable series for the last 3 years now during our October for Livers campaign. And one of the most inspirational and helpful things that I've seen that have come out of Global Liver Institute's campaign and awareness is being able to end these conversations now with the three of you to talk about what are ways that GLI can continue to focus on driving health equity and making changes. And I always kind of look for those takeaways on hearing your feedback. What goals or feedback do you have for me and the liver cancers department at GLI that for the next 12 months until next year's October is for Liver campaign, can we be challenged and be committed to doing to really increase benefits for rural health? Dr. Moon?
Yeah, so again, I want to reiterate how important I think this holding events like this is. I think, learning from each other and learning about experiences in other settings is incredibly important. I think moving forward, probably the largest public health impact is going to come from preventing liver cancers before they even happen. And I think that's going to occur by addressing the underlying chronic liver diseases, as we've all discussed today. So we're going to continue to be grappling with a rising tide of MASLD and alcohol-associated liver disease throughout the world. And probably the lowest hanging fruit right now is going to come from addressing viral hepatitis, for which we have very good tools to address. Chronic hepatitis C is the leading cause of liver cancer in the U.S. And we now have safe and very effective treatments available. So I think efforts like the National Hepatitis C Elimination Program aims to expand screening and testing and treatment of hepatitis C. And I think GLI can play a key role in helping to push efforts like this forward in the future to address chronic liver disease before liver cancer develops.
Thank you so much. Dr. Leavencliffe, your kind of takeaways and possible goals for Global Liver Institute and helping.
Yeah, I agree with Dr. Andrew Moon. The greatest part of it is will be preventing. And when I look about prevention in my context, I look at how GLI can support and strengthen in-country advocacy voices, especially with civil societies, how they can play a role to strengthen civil society organizations for advocacy, because prevention comes with policy changes that will limit alcohol consumptions, policy changes that will foster early diagnosis, policy changes that will preserve life and save health. Without that, prevention becomes very, very difficult. So my main takeaway to GLI is how they organize to support and strengthen in-country players and partners for greater advocacy, and the avenues that they will create nationally for these civil society actors and globally, so that their voices will be heard at national level, national policy level, and as well as global policy level. Because there are three ways to advocacy: the subnational, national, and global. And if advocacy is not strengthened across these different levels, we will not have the desired change that we are looking for. So how does GLI look at national, subnational, national, global advocacy, and how they strengthen civil society actors in liver health to actually get this? And secondly, how do we support patient movements or patients clubs within country? Because this is something that has been greatly ignored. Patients are not empowered, their voices are not being heard. How do we ensure that patients themselves have enough voices for them to make meaningful decisions when it comes to your health, and how they can be engaged in taking charge of your health? It's very, very important for us to see how GLI can support. So I think this will be my two takeaways: supporting advocacy, and also how patients are being empowered to take charge and manage their health.
Thank you, Dr. Leavencliff. And Dr. Lita Vera, certainly it's not the last comment that you're giving, but we're certainly really excited to hear what you think about ways that GLI can support some rural healthcare initiatives for you.
Well, I think roundtables like this are very useful, of course, not only for physicians, but also for the patients and for the people that make public policies. I think that when the patients understand, of course, in their own way, the nature of their disease, it's the most helpful way to provide them the health care that they need. This allows them to understand, for example, why they have to have alcohol abstinence, or why they must lose weight, for example, why they have to take their medications every day, and why it's very important to be at the hospital for every consultation, because these troubles that we have to face about the costs and the times for make these kind of travels, of course, some of them do not return to the hospital. And for the physician, it's very important because we have to recognize very early the liver disease. And as Dr. Moon told us before, the best way to help the patient is even prevent the chronic liver disease. So, for example, if I'm in my office and I see a patient with diabetes and they have another metabolic risk factor, well, I can't wait until they develop any kind of liver disease. I have to go and make an ultrasound or ask for some lab tests. I think that the prevention is very important, and these roundtables allow to think about prevention. And of course, the people that make public policies, because I know it's a dream to have an hepatologist in every city, but at least I think there are a lot of work to do to make maybe a network for make easier the attention of these patients. One thing that I like very much about GLI is that you have on your website information for patients in different languages. So it's very important for them, because this can spread the knowledge and the visibility that we are looking for.
Thank you all. This conversation could go on for hours. We could do an all day or an all week conference just on this, but I'm truly grateful for the three of you being with us today, for us to be able to dissect three different areas in the world that there are hardships and unique challenges for rural healthcare and advanced liver disease and certainly liver cancers. I'm thankful for the feedback that you gave to us. This is my promise to the three of you and all of those watching, our commitment to continuing to improve areas that patients and caregivers have access to support all of you as healthcare specialists. So truly my thanks, it's profound. And I really look forward to staying in touch and showing you what we're continuing to do. And thank you all in closing for joining us today in this important conversation. We're driving the learning and commitment that's needed to address health equity and allow us to push boundaries within our liver cancers community. Please don't miss out on our special health equity series that continues, that we continue to lay out in the coming month. And please turn in next week for more important conversations. For those of you watching today, if you'd like more information on our liver health and liver cancers program, or to utilize our important educational resources and materials, please visit our website at www.globalliver.org or www.livercentral.org. And please email us at cancer@globalliver.org for future suggestions or any questions that you have. Thank you again, Dr. Moon, Dr. Leavencliff, Dr. Lita Vera. Have a wonderful day, everyone. Happy October.
Thank you.
Thank you so much. Happy October. Have a wonderful evening, everyone.
Thank you.